Welcome everyone to today's program. I am Kathy Brett with Becker's Healthcare. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have and will follow up on questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program, and you can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Therese Poland is the Quality and Certification Specialist at the Healthcare Facilities Accreditation Program, or HFAP. Susan Lautner is the Quality and Patient Safety Specialist at HFAP in Chicago. Jeanne Robinson is the Stroke Advanced Practice Nurse, or Stroke APN, at Kettering Medical Center in Dayton, Ohio. It is now my pleasure to turn the floor over to Tess to begin today's presentation.
Thank you, Kathy. The Healthcare Facilities Accreditation Program is a nationally recognized not-for-profit accreditation organization with deeming status from the Centers of Medicare and Medicaid Services. Its mission is to advance high-quality patient care and safety through objective application of recognized standards. HFAP has been certifying primary stroke centers since 2006, and since then, as the standards have evolved, so has the growing need to diversify the program. The standards have been designed by a team of expert clinicians from both HFAP and non-HFAP accredited hospitals and representation from the Brain Attack Coalition. During this webinar, we will review the stroke system and advantages of stroke care. We will look at stroke-ready centers, primary stroke center, comprehensive stroke center, and Susan will take a brief look at data requirements before we close with collaboration. At this year's AHA-ASA conference, Dr. Mark Albert said, stroke systems of care provide a comprehensive, diverse, longitudinal system that addresses all aspects of stroke care in an organized and coordinated manner. Characteristics of different stroke centers include acute stroke-ready hospitals, primary stroke-ready centers, and comprehensive stroke centers. Following this webinar, clinicians will be able to identify the difference between 3 levels of stroke care, recognize which level your organization fits into, and connect with neighboring organizations to elevate stroke care region-wide, thus enabling each patient a seamless transition into higher levels of care according to their need. Advantages of care levels. Levels of stroke care help to organize hospital delivery structures through objective assessment, thus improving quality of care, identified quality outcomes, and reducing clinical risk. Knowing which level of care your organization meets and working safely towards recognized standards can facilitate a culture and drive towards excellence. This provides staff with an opportunity to build skills while providing the organization with recognition for achievement. Building partnerships with other organizations elevates stroke care. This ensures that all patients have timely access to the right level of care at the right time, thereby reducing disability outcomes and promoting optimal recovery. Three levels of care that we will go into further detail on are stroke ready, primary stroke, and comprehensive stroke. I'll now introduce Susan Lautner, who will speak about stroke-ready centres.
Thank you, Tess. First, I want to begin with a known fact that stroke affects more than 800,000 people a year, and it is one of the main causes of long-term disability of adults, older adults, and also one of the leading causes of death. Stroke-ready centers are also known as emergent stroke centers that provide for timely access to stroke care, but these types of centers may not be able to meet all the criteria specified in primary and comprehensive levels of care. Approximately out of the 5,000 hospitals in the United States, somewhere between 12 and 1,800 may fall into this category of stroke-ready centers. Stroke-ready centers serve as a notice to the community emergency medical service that the hospital is prepared to meet the initial needs of the stroke patients. Many stroke patients are in small, urban, and rural areas and do not have access to primary stroke centers or comprehensive stroke centers. And examples would include rural hospitals, basic care, use of telemedicine, and the drip and shift patients. Features of stroke-ready centers. They provide community recognition and information about stroke to small urban, suburban, rural areas. They provide access to stroke care for patients who do not have access to larger hospitals. There are working agreements with primary and comprehensive stroke centers to facilitate ease of transition of a higher level of care. Working and transfer agreements with EMS to provide immediate care at a close proximity, and administrative support and clinical leadership. And it's very important to have administrative support and clinical leadership, as this program should be budgeted, and there's also education requirements. Clinical elements of a stroke-ready center. They must collect and submit stroke data to monitor outcomes of clinical care, the development of evidence-based stroke protocols for management of stroke patients. And in this program of Stroke Ready, an ED physician may be the director of a stroke program. Also, the stroke code team arrives within 20 minutes. Lab testing and diagnostic capabilities are provided, and there must be a capacity to provide IV thrombolytic therapy and the use of telemedicine. Next, we're going to discuss primary stroke centers, and I'm going to introduce Jeanne Robinson. Jeanne?
Thank you, Susan. More of you may be familiar with primary stroke centers since the standards, since this was really the first developed certified stroke center, as Tess mentioned. Primary stroke centers have the capacity to stabilize and treat acute stroke patients. They provide initial acute care and administer IV TPA and other acute therapies safely and efficiently. Examples then include acute care hospitals with stroke units, and stroke units have been shown to have better outcomes when stroke patients are taken care of in stroke units. And these centers can also provide emergent TPA treatment. Features of primary stroke center then, they educate the community on stroke. It's so important to get those stroke patients to seek care emergently so that we can improve their outcomes. So that community education teaches recognition of stroke symptoms, the importance to call 911, and the role of EMS. The time is brain concept. Time lost is brain tissue lost. That there is acute stroke treatment available and what that time window for treatment is. And also that stroke is a preventable disease, and increasing their knowledge about healthy lifestyle. Other features include developing working agreements with Stroke Ready and comprehensive stroke centers. Also, developing a working and transfer agreement with the EMS. Providing stroke education to your staff and to EMS to develop stroke care knowledge and expertise. Also, that stroke data is being collected, and you are identifying areas for opportunity for performance improvement on at least 2 stroke measures or processes each year, which may or may not meet recommended benchmarks, but you see an opportunity for improvement. Also, as Susan mentioned, administrative support and clinical leadership is very important, and having a champion in administration is key. I think we need to go back a couple slides here for clinical elements of primary stroke centers. There we go. Clinical elements include stroke protocols that are developed for the management of stroke patients, and that the staff is educated and familiar with these protocols. That there is also a program director who is specialty qualified. That can be a neurologist, a neurosurgeon, or it could be internal medicine physician or an ED physician who has a special interest and some training in stroke. Also, a stroke code team that can arrive at the bedside within 15 minutes. This is really self-defined, so you need to look at your hospital and see, are you meeting this benchmark, and if not, how can you change that? For example, we had incorporated the ED-RNs into our stroke response team because they are triaging that patient immediately, and so that they can alert that ED physician that that patient needs immediate care. So that really helped us to solve that. When it's an in-house stroke, we use our our rapid response team and our nursing supervisors who have specialty education and go to evaluate that patient if the stroke team, the neurology stroke team, is not in-house. Also, lab testing and diagnostic capabilities include vascular and cardiac imaging. They must be able to provide IV thrombolytic therapy. There must be neurosurgical expertise available or able to transfer for that access and expertise within 2 hours. And they must have a stroke unit. Now, this unit could be within another nursing unit or an ICU, but the literature supports the importance of stroke units to improve patient care and outcomes. So on to comprehensive stroke centers. This is our highest level of care, and comprehensive stroke centers provide care for complex stroke patients. Their infrastructure is deep. It includes advanced treatments, necessary staffing, trained specialists in key areas such as neurology, neurosurgery, neuroradiology, neurointervention, and neurocritical care. Examples then include academic medical centers and tertiary care hospitals. The research unequivocally defines a difference between primary stroke centers and comprehensive stroke centers. The difference is based on clinician proficiency, use of performance measures to improve quality, patient outcomes, and the number of complex stroke patients that can be managed concurrently, and their higher level of acuity. Next slide. Features of comprehensive stroke center then include all of the components of primary stroke center, plus working agreements with stroke-ready and primary stroke centers. Analyze your region for the care that's provided and the capabilities of the hospitals in your region. Reach out, form those partnerships. Use the hub and spoke model to those hospitals that may be seeking a means to provide higher level of care to their challenging complex stroke patients. Also, advanced neurointerventional capabilities are provided at comprehensive stroke centers. Comprehensive rehab assessments and care are provided in a timely fashion. And discharge follow-up protocols, such as examples include stroke in a TIA clinic for follow-up control of risk factors, providing that patient education that maybe the patient was overwhelmed when they were in the hospital and didn't assimilate everything, to that stroke patient education, medication education, and ensuring compliance with the medication so that we can prevent secondary stroke. Also, anticoagulation clinics are an example of discharge protocols and follow-ups. And protocols also should include making sure that the patient sees the primary care physician, neurology, or other specialties that may have been involved, such as neurosurgery, neurointervention, cardiology, etc.
Also, there are processes in place that make it easy for the patient to get outpatient testing or therapies that are still necessary for their improvement in function, or even to increase their diagnosis and find out a little bit more about why did this stroke happen in the first place. And then developing a continuous research plan which participates in patient-oriented research makes this a feature of comprehensive stroke centers. Next slide. So clinical elements of comprehensive stroke centers include all of the components of primary stroke centers, including a program director that is specially qualified, a physician who is board certified or working towards board certification, a physician with either a stroke fellowship, a neurologist, a neurosurgeon, neurointerventionalist, or a neurointensivist. So this is a little bit more rigorous than primary stroke center. Lab testing and advanced imaging, which includes CT angiography, digital subtraction angiography, MR angiography, MRI with DWI, transcranial Doppler, transesophageal and transthoracic echocardiogram, extracranial ultrasound, carotid ultrasound. They must also be able to provide IV thrombolytic therapy. Neurology, neurosurgery, neuroradiology, endovascular experts, neurointensivists must be accessible and available 24/7. And the operating room must be available and ready to perform surgery within 2 hours of the order 24/7. There must also be dedicated ICU beds, which means that there is a plan in place, and that plan is available to the reviewer when they come that demonstrates the process for holding and arranging beds as required. The neurointensive care unit setting has coordinated rounds, telemonitoring, and staff with training and expertise in neurocritical care. An important note here is that the neurointensive care may be staffed by an advanced practice nurse. However, this unit must be able to access a neurologist via phone, and the neurologist must be on site within 45 minutes. Also, there is a stroke unit with specialty trained staff and telemonitoring, which is essential in this department, and that there are patient care protocols, which include required assessments with time frames, such as the NIH stroke scale. How often do you do that? When do you do it? And neuro checks. Protocols which outline the sequence and timeline for the initial physical therapy, speech therapy, and occupational therapy evaluations. The patient's significant other is involved in the care and post-discharge options, and this is reflected in the chart. A new standard is incorporated into all levels of certification, and this is clinical deterioration. The hospital establishes a system for recognizing and managing clinical deterioration in patients who present with acute stroke symptoms. This standard is in reference to those patients who present to the facility with symptoms of acute stroke and current inpatients for whom the stroke team is called to assess and intervene. So you need to develop some type of a written document which provides guidance to the staff on how to recognize stroke symptoms and manage the associated clinical deterioration which can take place. We actually developed an algorithm. I have one for the emergency department and a very similar one for in-house stroke for those patients who are hospitalized for other reasons and who may develop stroke symptoms. This is displayed at the charge nurse desk for nursing, and physicians also find it valuable because oftentimes they're not sure exactly what to do and when to page the stroke team, and also it's all right there for them. And then I provide annual education on this algorithm. So next I'm going to turn it over to Tess to talk about the clinical differences.
Good. Thank you very much, Jeanne. Can we please go back to the previous slide? The previous slide is actually a snapshot of the clinical difference between all three programs. Note here that in regard to QAPI for Stroke Ready, the organization focuses on building quality projects around elements that have not been fully met, such as standards and performance measures. The primary and comprehensive centres must demonstrate performance improvement on at least 2 additional benchmarks each year, and all levels must monitor adverse outcomes. A neurologist must be on site at a comprehensive centre within 45 minutes, 24/7. Neurosurgical expertise may be accessible via telemedicine for stroke-ready centres, and for comprehensive centres, they must be on site within 30 minutes, 24/7. In relation to nursing education, stroke-ready centres include stroke-in services for healthcare professionals. Primary and comprehensive centres must also have a stroke coordinator and specific training for members of the stroke team and those that work with stroke patients. For example, in the ED, ICU and stroke units, they must have up to 8 hours of training each year, specifically on stroke, and that's the acute stroke response team members. However, for the ED staff, it is 2 hours, and for the ICU and stroke units, that will be 6 hours annually. As you can see here, the diagnostic modalities are more sophisticated for comprehensive stroke centres. When we look at the comprehensive centre, volume is essential for number of subarachnoid hemorrhages, clipping and coiling, and again, this is reflected through interventional capabilities. That all has a flow-on effect to clinical care for those patients in designated ICU beds and stroke units, which Jeanne provided an overview of. All centres require a stroke team. The only difference here is a 20-minute response for stroke-ready centres. Rehabilitation is essential, and one thing I would like to highlight here is that the comprehensive centre's requirement to provide follow-up. Some facilities have adopted an outpatient stroke clinic model to complement their infrastructure. And finally, education requirements are different for the Stroke Ready Centre in that they are only required to provide education for patients and significant others, whereas primary and comprehensive centres must provide education to EMS, stroke team, and the community. I will now move forward to the next slide where Susan will discuss clinical data.
Thank you, Tess. You can go to the next slide, please. New this year for CMS reporting, and that became effective January 1st, hospitals are required to report data on 8 CMS hospital inpatient quality reporting programs to receive full Medicare benefits in the year 2015. If hospitals fail to submit the data, they risk receiving reduced reimbursement beginning 2015. At this stage, the hospital IQR program bases reimbursement only on the action of reporting the data. Again, it's just the action of reporting the data. Next slide, please. This slide here shows the 8 elements that is now being submitted to CMS. You have thrombolytic therapy that has to be started within 0 to 3 hours. Antithrombolytic therapy by the end of hospital day 2. It's the patient's discharge and then antithrombolytic therapy. There's anticoagulation therapy for atrial fib or flutter, and VTE prophylaxis. Also, with the patient's discharge on statin medication, again, stroke education, and assessed for rehabilitation. So again, those have to be reported to CMS, and that is just, again, the action being reported of it. Next slide, please. Validating accuracy. Validating the data is important in your data abstraction. This slide is a flow chart for pay for reporting, starting with the patient encounter, the case coded and billed, case abstracted, then the case is submitted to CMS, sample of the cases are validated, receive your full Medicare payment, and then the data is publicly reported. And some of the stroke registries also require at least 6 records a quarter that are to be validated. Next slide, please. In the direction forward, this is for the future of data submission, it may be possible that the value-based purchasing program will penalize hospitals for not meeting performance standards for the data being submitted to CMS. This means that hospitals should start now to work towards improving outcomes in their measurable areas. Again, it's just they don't know what the score will be, but again, it's important to be submitting your data and looking at your outcomes. Again, this is another flow chart regarding value-based purchasing, and it begins with the patient encountered, and it goes through the cases coded and billed, abstracted and measured, and submitted and validated, and ending again with the data publicly reported. Please notice in the flow chart that achieving a measurement score is yet to be determined. I can't emphasize enough how important it is, and Jeannie explained it too, that look at what you can improve on. Tess, I'm going to turn it back over to you, and you can cover the collaboration.
Thank you, Susan. Next slide, please. Effective stroke care requires coordination of the activities and resources of a broad range of individuals, facilities, and organizations to ensure that the appropriate patients are receiving care from the appropriate providers in the appropriate amount of time. This is a quote from Schwab et al. Recommendations for the establishment of stroke system of care from the American Stroke Association's Task Force on the Development of Stroke System. It is through collaboration that you get to know your neighbour. Start by performing a search on the hospitals, small and large, in your area. Identify what level of stroke care they provide through their emergency department, then go beyond metropolitan hospitals and consider what access neighbouring rural hospitals have and extend partnership. Partnership can overcome treatment inequities in remote regions and ensure the best possible care is disseminated throughout regions. Note that telemedicine plays an integral role in the development of regional stroke care networks. Consider your telemedicine capabilities. This is a graphic example of the hub and spoke model. The Comprehensive Stroke Centre, depicted here, though there are only a few, has a social responsibility to connect and partner with both primary and stroke-ready hospitals in their region. Primary stroke centres also have a social responsibility to connect not only with comprehensive but also with neighbouring stroke-ready and other primary stroke centres. And it is through the collaboration that the hub and spoke model is created. Consider where your organisation fits and what partnerships you can create through collaboration. How many spokes are in your hub? Thank you. Susan.
Formalizing your level of care. HVAP is the only private not-for-profit organization that offers 3 levels of certification: Stroke Ready certification, Primary Stroke certification, and Comprehensive Stroke certification. The HVAP Advantage. Any hospital with accreditation from another organization or those accredited by the state may apply for stroke certification with HVAP. This is a 3-year cycle with a mid-cycle review. Standards developed by experts in the field for this program, and some of the experts included Dr. Mark Albert, Dr. Tim Schoonover, and nurse practitioner Deb Bergman. This is the contact information, and we'll leave this slide up, and we are ready for questions.
Okay, well, thank you for a very informative and enjoyable presentation. We're now going to begin the Q&A portion of the program, and as a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as we can during the time we have left for Q&A, and we'll follow up on any questions they do not have the opportunity to address. I'm going to start out with the first question we have here, and this one is for Tess. Will an EMS bypass a non-certified hospital?
And that depends on the state. Some states actually have activated an EMS bypass system, and other states are working toward them. So if you have any questions regarding your state, please send us an email at stroke@hvat.org.
Okay, thank you. Another question we have here, this one is for Jeannie. What are the advantages of being a comprehensive stroke center?
Well, there are many advantages. First of all, quality, growth, competitive edge, financial optimization, and increased patient family satisfaction, and increased staff satisfaction. So let me just expound upon those a little bit more. Basically, with quality, you have improved patient outcomes and quality of care with comprehensive stroke centers. So that's the main goal. Since Comprehensive Stroke Center is the highest level designated recommended by the Brain Attack Coalition and the American Heart and Stroke Association to provide complex care for stroke patients, they can provide that consistent high quality of care. And they really raise the bar in terms of providing evidence-based care to meet the needs of more complex stroke patients. The hub and spoke model provides an orchestrated way to care for these complex stroke patients within and outside your community, and it encourages this partnering with stroke-ready primary stroke centers and also rural hospitals to improve patient outcomes. It also helps to reduce the burden of stroke in terms of loss of function and financial burden from loss of productivity, nursing home care and costs, and the burden on the family to care for the patient at home. There are multiple categories of stroke patients that comprehensive stroke centers take care of: ischemic stroke and TIAs, aneurysmal subarachnoid hemorrhages, unruptured aneurysms, non-traumatic hemorrhages, and hemorrhagic versus non-hemorrhagic arterial venous malformation. Best practice organizations really administer TPA at a much higher rate, more like 18% or greater of their total stroke population. And best practice comprehensive stroke centers perform interventional stroke treatments for approximately 15% or more of their stroke patients. In terms of growth, it's really similar. The whole structure is similar to the trauma model. And when you think about EMS delivering acute strokes to certified hospitals, they know to do that. But EMS may not be able to differentiate the care that's required or how complex this case is. So they may be more likely to deliver, if there's a comprehensive stroke center in the area, to that comprehensive stroke center. And then that hub and spoke model basically builds partnerships and confidence, not just in stroke care, but then in other services. As far as competitive edge, it establishes expertise and leadership in neurosciences and can increase stroke volumes. It can also increase your volume in neurointerventional, neurosurgical, neurology, and other specialty services such as cardiac, radiology, rehab, other surgeries including elective cases, and other inpatient and outpatient services. So that gives you that edge. It also facilitates recruitment of specialty physicians, especially high-demand disciplines that want to be more productive and want to be associated with a hospital that has highly recognized quality of care and advanced technology. It also encourages patient-based research, and that's a patient and a physician satisfier. In terms of financial optimization, TPA administration doubles reimbursement for stroke patients. It also increases your volume of those other high-end cases, such as neurointervention and neurosurgery and other neurology cases. It also may help, if you have a stroke patient who has a seizure, then if you have an EEG epilepsy monitoring unit, it'll provide volume for that also. And then lastly, I think it increases patient and family satisfaction when those patients have improved outcomes and function. And also staff satisfaction, because staff has this ownership and pride in the care that they provide and that they know is being provided at their facility.
Thank you. This next question is also for Jeannie. You mentioned stroke units and the fact that they can be part of another unit. Please elaborate on what a stroke unit consists of regarding staff, beds, equipment, etc.
Well, of course, you need telemonitoring so that we can determine, what's the etiology of the stroke. Is it maybe AFib or something? And oftentimes patients who have strokes who have cardiac complications during the stroke, not just as a precipitant. Also, as far as how many beds, well, you have to really look at what you have and what you can offer, what's your volume of strokes and TIAs that you're getting. It's very important to have stroke order sets that evidence-based, and how often are those neurochecks. Our neurochecks for regular strokes, not for those who got TPA, are every 2 hours for the first 24 hours. So making sure that you have staff on that unit that can provide this care. And this staff must have specialty stroke education, whether depending on the level of the stroke center, but basically, these nurses and nursing assistants and all staffs are taught to recognize deterioration, that this patient needs a swallow screen or to keep them NPO, that these patients need to have therapies immediately, and when they need to call the physician about a change in the patient or when that patient needs to be transferred. So those types of things are very important in calling it a stroke unit. And when I say it can be included in another unit, in the ICU you do have the telemonitoring and the nurses have critical care experience, but you need to incorporate that stroke education also into it. And making sure that all nursing staff understands what are the performance measures, what is best practice for stroke. So that's another thing that we do, is making sure that if we do have patients that go to another unit, which isn't very often, our bed control does a fabulous job, but we make sure that the other units also are aware of best practices for stroke patients, and we do basic education on stroke for every employee, and then we do different levels depending on where they work. All nurses get certain education on recognizing stroke, knowing what to do, how to take care of them, and how to page the stroke team until they are transferred to an ICU for a patient who might be hospitalized for another reason and then suddenly have a stroke. Does that answer the question?
I believe it does. This next question is for Susan. If a TIA patient has rehab therapy ordered but is discharged prior to being seen by a therapist, is this patient excluded from numerator, denominator for this indicator?
Well, that would depend if TIA is in the stroke population that they're measuring that measurement on. And can you reread the question again, please?
Hold on. My question just went away.
Okay,
So
if a TIA patient has rehab therapy ordered but is discharged before being seen.
Being seen by a
again,
therapist, yes.
Yeah, if it's included into their, if a TIA patient is included in their stroke population, yes.
Could I just
If
add
you would
something
want
to
to know
that?
what. Go
Could
ahead.
I just add something to that? And this came up in our institution recently. Basically, if the physician documents, for example, maybe the patient got back to normal, so in that case, as long as the physician had documented that the patient was back to normal, or if the patient refused, those would be reasons that it would be acceptable.
That's correct. Documented reasons in the chart.
Okay, thanks.
I hope that answers the question.
This next question is for Susan as well. Does HFAP have agreements with GWTG outcomes?
With Get With the Guideline outcomes, we do not have agreements. Our standards ask that that is up to the program if they want to report to Get With the Guidelines. That is voluntary. We highly recommend it.
And
Okay,
I'd like
great.
to add to that also, we have the Paul Coverdale registry also, and although we don't have agreements with them, it's usually between the hospital and Get With the Guidelines. And I do believe that from time to time, Get With the Guidelines can sponsor hospitals to join Get With the Guidelines. So sometimes they offer some sponsorship opportunities. And although at this stage, CMS do not require you to be part of a data organization, they do ask whether you're part of Get With the Guidelines or Paul Coverdale registry. The benefits of being part of a registry is that you have local, state, and national benchmarking opportunities, and also the data that goes into those registries facilitates research and advancement in clinical care outcomes.
Thank you,
Okay,
Jeff.
thank you. This next question is for Jeannie. How do you initiate the conversations with other stroke centers? I am a stroke coordinator at a large PSC with a few competing CSCs within an hour from our hospital. How did you get everyone at the table to work together?
I think that's a huge challenge, and I think the biggest thing is we need to look at is what's best for the patient and the population, and making sure it's really a social obligation to make sure that it isn't all about competing hospitals, but is that patient getting the care that they deserve in a timely fashion. And so a lot of places, a lot of regions will have meetings where people come together, they put down their political bags, and they come in just thinking about the patient and how they can improve the care in the region. And so maybe working out some kind of a map or something like that would be what's looked at as best practices for the patients that may have challenges in that region. That takes a while, I think, to build, but I know that a lot of geographic areas have done that and done it very successfully.
Okay, thank you. Jeannie, what about TPA use? It seems there is some controversy recently in its use.
Well, I'm a little confused on that question. Can that person elaborate a little bit more? I mean, years ago there was question as to whether it was safe, but then they found out really it was violations of protocols, and it is deemed a safe drug if used in the appropriate population and under the appropriate protocols. I'm not sure exactly where they're going with this. If they can type in a little bit more or elaborate more.
Okay, we'll see if the attendee who asked that question can expand a little on the question. In the meantime, Tess, we have a question for you. For a rural hospital, is there a model of structure to use in setting up a stroke team?
Yes, actually we have stroke-ready standards that are available on request. If you email into stroke@hvap.org and request a copy of our stroke-ready manual, we will organize that to be sent to you, email you a PDF copy. In the development and setup of new programs, we have several hospitals that are transitioning or wanting to become stroke certified at one level or another. We also offer bi-weekly teleconferencing just to support the staff with and getting on board, as well as providing standards interpretation just to facilitate the development of stroke centres. So drop us a line at stroke@hvap.org and we will send you a copy.
Thank you. The same attendee goes on. Oh no, this is another question. For rural stroke-ready centers, can the EDMD from the telemedicine serve as medical director and get radiology read on CT in the 45-minute window? This seems to be the nearest primary stroke center or comprehensive stroke center, or then send to the nearest primary stroke center or comprehensive stroke center.
Yeah, there's a few questions in there that we would have to talk a little bit more about the situation and define if there is a doctor physically present on site. That's important. And then telemedicine can be initiated and orders prescribed and then transferred to the nearest primary or stroke ready. But we would need a little bit more information regarding the structure of the primary or the stroke ready facility.
Okay, thank you. I have a question for Susan. Susan, how were your standards developed?
Our standards were developed. We all had a expert panel from a broad range of stroke experiences, and it included stroke coordinators, medical doctors, doctors of osteopathic medicine, and they were from just nationally from all over, and put a lot of thought and their experience in it, and we, if they want to contact us again, we can send out, specifically who is on the experts who are on our stroke manual, but they're recognized in the field, definitely.
Okay, thank you. Tess, this question is for you. Can a telemedicine neurologist be part of the 15-minute stroke response team?
There needs to be a physician present that is able to arrive at the bedside. So a 15-minute response is a primary stroke center or a comprehensive stroke center, and you would require a physician to be present at the bedside. And you can access telemedicine at the same time, but there needs to be a physician. I don't know if you want to add anything there, Jeannie?
I don't know. That's becoming a little sticky because if you have a robot that can assess the patient and all, so I think that that's something that probably will be looked at down the road as a means, since there are a shortage of neurologists. But I think that would be really up to HVAP to determine what is acceptable for them.
All right, thank you. Tess, this is also for you. The telemedicine ED model is staffed with RNs and board-certified EDMDs 24 hours a day, 7 days a week.
I think I would need more information around that question.
Okay. The attendee who asked that question perhaps can elaborate a little further. And we'll just go on to the next question here for you, Tess. What are the advantages of choosing HFAP certification over the Joint Commission certification?
We often get asked this question in our travels, and some of the most advantages that we have is that we offer the bi-weekly teleconferencing. The second point here is that we offer a 3-year certification cycle. In addition to that, we have observed quite a large number of hospitals deciding that they want accreditation and certification at the same time. And we've been able to marry up the certification in line with accreditation. And I believe they're the main advantages. We're also very strong and focused around education and upskilling clinicians who work with stroke patients.
Thank you. Tess, what is the difference between your stroke programs and the other accrediting organizations?
Clinically, there is not a lot of difference. We have experts who come from hospitals that are certified by other providers, and so we have a very broad, eclectic range of experts. We also have a combination of doctors of osteopathic medicine, medical doctors, and registered nurses and nurse practitioners that balanced the standards quite well from both a clinical and a practical perspective. But clinically, they are equally comparable.
Thank you. You mentioned the difference between stroke-ready and primary stroke. Can suburban hospitals become stroke-ready?
Absolutely. Suburban hospitals can become stroke-ready. Actually, we are working with one hospital that has a primary stroke centre, and down the road they have an emergency department, a standalone emergency department, and they're using the emergency department as a drip and ship to the primary, and becoming stroke-ready certified for the standalone ED facility.
Okay, thank you. We have time for just a couple more questions. This question is, if a patient is discharged from the ER with a diagnosis of TIA, is that patient included in the data numerator denominator of performance measures?
I can answer that one. Again, it depends on what they define as the stroke population. And from my experience, usually the TIA has recovered and has been discharged. So usually they are not included. Does any Tess or Jeannie, did you want to add anything to that?
I agree with that. The biggest thing would be the concern to make sure that that patient got the proper workup in a timely fashion and didn't go on and develop a stroke. We usually at least put our TIAs in for observation. But as far as in the measure, I agree with what Susan said, that they would not be.
Great, thank you. This question is for Susan. How were the stroke measures selected?
Again, with the expert panel that we had, and also the metrics paper that was for the comprehensive stroke standards that was written by the American Heart and American Stroke Association. So those measures are actually closely linked with the design of the standards in our programs.
Okay, thank you very much. Okay, I want to thank all of our presenters today for their excellent presentation and for all of you attendees who participated in today's webinar. We look forward to having you join us again. And this will conclude today's program, and have a wonderful afternoon. I just want to remind you that if you want to contact the presenters, you can email them at stroke@hfap.org, or you can phone them at 1-800-621-1773. Thank you very much.